Good morning, everybody, or good afternoon, depending on your time zone. And I'm so thrilled to be here and be a part of this program with the Axia Institute of Michigan State University. I first want to thank Christopher Jerry for sharing Emily's story. It's such a powerful story. And Christopher, thank you for driving change and working so diligently to stop these avoidable tragedies. Both you and Emily are truly aspiring for all of us to do better. So thank you so much. I also wanted to acknowledge Michigan State University's supply chain program. I know the Axia Institute is very much involved with the supply chain world and making improvements, and I read that the program was recognized by U.S. News and World Report as being ranked #1 in the nation. I believe this makes it 10 straight years in a row. Excuse me. So kudos to you, congratulations, job well done. So today I will be talking a little bit about securing the medication supply chain, but through the lens of the hospital executive with a fiscal focus. You're going to hear later today a lot about patient safety and advances in technology related to that. And while this does have patient safety components, I'll be really touching upon the fiscal focus. So let me get started. I assume you can all see my screen. All right, so I have no conflict of interest to declare related to this presentation. Just wanted to make that clear. And I wanted to keep the requisite bio slide brief. I simply want to give you some context to my background and recent changes in my role. I just moved a little less than 2 months ago from the Los Angeles area, where I served as the Chief Nursing Officer with M&A Health, Queen of the Valley Hospital. And this is actually the hospital system where I implemented the technology that I'll be discussing in this presentation. Currently, I have the distinct pleasure of working with Sutter Health as the Chief Nursing Executive at Sutter Delta Medical Center in Northern California. So again, please forgive me if I jump between pronouns of us, they, we, and them, just because I'm still getting acclimated here. And I'd also like to share, I may be an anomaly, but I have developed a true passion for supply chain management and logistics over my career as a registered nurse. And I'm sure that my experience as a surgery nurse is what prompted my interest in this, as it's kind of sad, but you'd be in the middle of a case with a patient on the table and you'd be run out of a supply. And I truly believe that supply chain management in hospitals remain low-hanging fruit related to cost control. And I have to share a quick true story. When I was in my MBA program working on a group project in my operations management course, we had my partner happened to be the head of supply chain for wet design. Now, this is the company that creates so many of the famous fountains around the globe, such as Dubai. You probably all are aware of the Bellagio fountain in Las Vegas. And when we started this project in the operating room, he was shocked when I would tell him stories about how we would run out of a product while a patient was on the table. And unfortunately, this does happen. And he mentioned that if he didn't have a required part to the job site on the date it was due, that his reputation would be tarnished. And we are talking about fountains he was building. And this begs the question, why has healthcare lagged with adopting best practices for supply chain management? So how your supply chain is managed can be the difference between wins and losses. Many credit the victory in World War II to how the logistics were managed. Getting weapons, ammunition, food, medical supplies to the troops provided the means to success. And it's no different in the healthcare industry. You don't have to look too far to find that our inability to supply the appropriate PPE to our frontline staff during this COVID pandemic has made battling this disease even more challenging. And I'll bet that most of you listening today remember the challenges with getting IV fluids due to Hurricane Maria in Puerto Rico. The bottom line is that good supply chain management is foundational to the success of any business, and healthcare is not immune to this requisite. Now, before I discuss how we tackled securing and managing medications in the operating rooms across M&A Health, I believe it's important to look at how technology is viewed by some hospital administrators. Hospitals have been expected to meet certain requirements related to implementing an electronic health record. And quite frankly, the technology is seen as a check-the-box requirement, and it's often difficult to quantify in many healthcare organizations the financial benefit. Now, let's take, for example, how well technology has helped the airline industry. Just like Christopher Jerry was saying, talking about the airline industry and his examples. When the self-service kiosks were implemented, labor costs reduced significantly. They were able to leverage the technology to lower overhead costs. In healthcare, once the electronic health record was adopted, we increased the number of staff in the labor pool, for example, scribes, and of course, help desk personnel. Healthcare often fails to leverage technology to its fullest potential. You know, it's funny how healthcare can be so incredibly innovative with procedure and medication advancements, yet still rely on the fax machine and pagers. And this is just to give you an overall understanding of why some administrators are gun-shy with adopting other technological advancements. But once you can demonstrate how technology can reduce costs, whether through labor reduction or improve patient outcomes, or both, then you can gain buy-in. Today, I'll be discussing medication management in the operating rooms. You know, I've worked closely over the years with pharmacists in my organizations, especially directing surgery departments. And what I consistently hear is that the operating room is the black hole of medications. We struggled, as do many hospital surgery departments, with tracking anesthesia medications. Excuse me. This impacted our ability to gather accurate data to set par levels and hurt us with managing our 340B program, causing increased cost, waste, and avoidable stockouts. And I'll discuss the 340B program in more detail later. Myself, along with M&A Health's Corporate Director of Pharmacy, Paul Morris, set out to find a way to combat this challenge. And we were fortunate enough to discover Intelligard, which is a technology that uses RFID, radio frequency identification. So what were our goals? We knew that we needed to clearly define our objectives in order to select the right solution and to ultimately gain the CFO support. This slide highlights some of the key areas of opportunities, such as managing the 340B program, improving access and security within the ORs and procedural areas, reduce inefficiencies and errors that are caused through the manual process, reduce medication stockouts, and tighten the controlled substance and reconciliation processes. And obviously, to better manage inventory and utilization, and ultimately decrease waste. While there are some safety-related components to this list, it really does show a financial opportunity. The 340B program for us was the most pressing issue that we were facing. And like many hospitals and healthcare systems, M&A Health participates in the federally regulated 340B drug pricing program. There are many challenges when managing a 340B program, including potential audits at any time and the risk of unintentionally violating government regulations. We faced several obstacles when managing the program that kept us from taking full advantage of its benefits. Medication was managed manual, time-consuming, and error-prone. This was particularly a challenge in the operating room, where we had very little visibility to the medication usage. This all resulted in lost medication charges in the operating room and procedural area locations, adding to the substantial financial loss for the 340B program. And this is a program that is designed to save money. Now, I'm sure many of you are very familiar with the 340B program and how it works, so I'll be brief on this slide. I just wanted to touch upon the pricing buckets, since this is relevant to the results I'll discuss in later slides. With the 340B program, eligible facilities can purchase medications at a lower cost. There are three possible ways you can make these purchases in the pharmacy. It's through wholesale acquisition cost, or we refer to that as WAC, or through contracted group purchasing organizations, or GPOs, and then through the 340B. Now, when you first start your 340B program, you are required to purchase at the WAC pricing. And more often than not, this is the highest cost. Now, if you document and track these drugs used on eligible 340B patients appropriately, the organization can then replenish the medication through 340B pricing, which is usually the lowest cost. And of course, the GPO is used for the non-340B eligible medications. These prices usually fall between the WAC and 340B. So who is Intelligard, and what do they offer, and how did they help us? So Intelligard designs, manufactures, and implements intelligent healthcare supply chain management solutions, and they're powered by RFID. I believe that they are leading the revolution towards a more efficient and effective system to track, trace, and manage medications. And they provide a comprehensive set of RFID-powered hardware and software products which can manage medications across the hospital supply chain. So let's talk a little bit about barcode technology versus RFID. And Christopher Jerry is talking about the barcode technologies that are available in hospitals. And that is by far the most commonly used technology to manage medications today. But I like to use the analogy of runners in a marathon when comparing these two technologies. Today, the bibs that runners wear are embedded with an RFID chip. Now, let's imagine if at the finish line someone needed to scan a barcode on the bib rather than the automatic capture through RFID technology. The organizers of the race would need to add additional staff. Times would be less accurate, and some runners would be missed altogether. And as I was saying today, the most common way to track and manage medications in the acute care setting is through the use of barcode technology. However, barcode medication management requires a line of sight and is a manual process. And while barcode technology is widely used, it lacks efficiency and ultimately lowers compliance. Conversely, RFID automates the entire medication process as it relates to tray restock, tray processing, dispense management, narcotic waste management, and accurate documentation capture. RFID is leveraged in many industries effectively and can certainly translate to healthcare to deliver the benefits such as automation of manual processes, reduced labor costs through improved productivity, improved accuracy by eliminating human error, improved compliance and safety, accurate data collection which allows for predictive analytics, and ultimately reduces time managing supply chain elements. Just to stress the advantages of RFID over barcode scanning, RFID can simultaneously scan hundreds of drugs accurately, automatically, and without error. So we implemented these solutions from Intelligard at M&A Health. The pharmacy station pictured on your left is an RFID-enabled kit and tray processing system that provides fast and accurate inventory replenishment and tray management. M&A Health adopted this solution and it immediately led to fewer errors, more effective identification of expiring or recalled medications, and we all know recalled medications is very challenging to manage. And we saw improved reconciliation capabilities. The pharmacy station essentially acts as the heart of Intelligard product solution set. In the pharmacy, medications are tagged and encoded with data, and then read points are established throughout the hospital to enable tracking and visibility of the medications in all locations. One of these read points is the Intelligard anesthesia station, as pictured on your right. These anesthesia cards can be found in every operating room, across M&A Health, including some procedural areas. The Intelligard anesthesia station houses all the medications, including controlled substances, in locked drawers with secured access. It automatically tracks every transaction and dispense narcotic, providing controlled substance reconciliation, saving time while enhancing security. Of course, the ability to track in real time what the cart's inventory levels are ensures that necessary medications are always available for the anesthesia provider, reducing the potential for case delays and improving patient safety. Another benefit of adding the RFID medication management to the operating room is the level of harmony created between pharmacy and the OR. Anesthesia is no longer calling pharmacy to report missing medications, and pharmacy is no longer demanding that anesthesia spend considerable time documenting their medication transactions. And while safe patient care is the top priority for any hospital, being fiscally responsible cannot be ignored. I argue that we can accomplish both. Some opportunities that we realize with the utilization of Intelligard are listed on the slide. As an example of how an organization may use trends in utilization practices, consider the usage of Sugamidex, a high-cost reversal agent, at approximately $100 a vial. This system gives us the opportunity to create scorecards by anesthesiologists to show frequent users, identify best practice to improve neuromuscular blockade usage, and consider using alternative agents to reduce sugammadex spin. Now, this is just one example, and I definitely don't want the anesthesiologists out there to believe that we want to force them to change their practice, but this has actually been very helpful for our medical director of the anesthesia group, because it allows him to see what the actual usage is by provider, and they can address best practices within their group. And of course, accurate charge capture is especially important. Any medication given in the OR that is not documented will need to be repurchased at the WAC price. Again, this is often 2 to 3 times more expensive than purchase at a GPO pricing or 340B. In addition, if you can accurately capture dispensations for all outpatients, you are able to repurchase those medications at a deep discount. And of course, key to any supply chain management is optimizing par levels. But in the absence of data showing medication utilization in anesthesia trays, hospitals tend to stock significantly higher levels of anesthesia medications to avoid stockouts during a procedure. However, this can lead to a significant amount of waste. And imagine for certain short-dated medication, such as succinylcholine, this can lead to excessive wastage and thousands of dollars in additional spend. I often refer to and this is true within supplies within an operating room in general. When you have nurses and techs managing supply chain, they don't want to run out. That's fresh in their mind, so they have that Costco mentality. They'll run out that one time, they'll bulk buy, we'll end up with expired items, but the process itself never gets fixed. And of course, we want to mitigate risk related to compliance. Intelligard automatically tracks with dual authentication all transactions related to narcotics. Due to automated tracking of all narcotics, the risk of diversion in the pharmacy, during pharmacy transport, and during the procedure drops significantly. The amount of time required to track discrepancies also decreases, a true benefit for both pharmacy and anesthesia, and this ultimately improves productivity. So here's an example of the transparency we have with the system. The table above shows the disparity between all medications pulled out of the Intelligard versus all documented as given in the electronic medical record. If you look at the top example of ephedrine, you see that in September 2019, this drug was pulled from the anesthesia Intelligard 146 times, but was only documented 100 times. So that is 46 vials that are unaccounted for. And while we're unable to differentiate in this data if the medication was wasted or not documented as given, however, the results are all the same. All of the medications in the sample provided above must be repurchased at the higher WAC price. Any opportunity to purchase these at a significantly lower 340B price has also been lost. By reviewing the data by provider, we can identify those anesthesiologists with the best performance. From their example, we can set a process to ensure that we are not needlessly pulling drugs up in advance or not accurately documenting all medications that were given. Also, as can be seen in the above example, hospitals do not all perform equally in their related to documentation and wastage. And this can be used to identify any trends in culture that may affect lower performance. You know, the above medication example is just a small snapshot of what we're able to pull and easily identify, but imagine this for every drug that is stocked in the anesthesia carts and the potential financial implications. You know, in conclusion, our post-implementation accomplishments exceeded our expectations, especially for the pharmacy team. First and foremost, the implementation process was one of the most smooth and, dare I say, easy implementations experienced. As with any new product or software implementation, there was some staff apprehension, especially among the anesthesiologists. Post-implementation, both pharmacy and anesthesia teams found the systems had virtually no learning curve, and the hardware installation process was easier than anticipated. End users reported Intelligard as the easiest technology implemented to date. In fact, I'd be remiss if I didn't mention an example of how intuitive the hardware is to use. We had pharmacy personnel OR on our go-live date to support the anesthesiologist. And there's one OR that's kind of hidden at the Queen of the Valley Hospital, and the pharmacist didn't realize it was there, and there was a case going on. Once he learned of this, He ran quickly to the OR, and the anesthesiologist was already finishing that case. He was able to manage and use the technology seamlessly. Beyond the implementation, we were able to replace outdated paper-based processes with RFID automated processing of kits, trays, and crash carts that freed up valuable time for pharmacy staff to work at the top of their licenses. RFID tags on each medication enable tracking at the item level to ensure 99.99% medication accuracy in the OR. This resulted in more accurate dispensing reports and analytics, and ultimately recouped OR charges benefiting the 340B program. In addition to enabling accurate medication tracking, Intelligard improved accountability for controlled substance management, helping to mitigate future diversion events. Intelligard has proven to be successful at M&A Health. Unfortunately, with COVID, which hit us approximately 6 months post-go-live, M&A Health has not taken full advantage of the data. However, they do have accurate and actionable data to use today, which is not the case at the beginning of our journey. And I want to also mention, the quote that Christopher Jerry shared, that we must accept human error as inevitable and designed around that fact. This has been the reality with us, that we see human error, we know it's there, and we recognize the opportunity with this RFID solution. So I believe truly that this is the advancement for medication, especially in the operating rooms across the nation and the globe. Thank you all so much for your time and attention. I do want to acknowledge again Paul Morris, the Corporate Director of Pharmacy from M&A Health, who I hoped would join me on this presentation. He really drove the implementation and made it really successful. And here you see I've included my email address for the audience. Please feel free to reach out to me if you have any questions that you may have. I'll turn it back to you, Bill. Thank you so much.